Good morning, everybody. Welcome to the RCN webinar. We're going to wait a little bit as our participants trickle in and start at 8:02. While we're waiting for everyone to trickle in, I just want to draw your attention to this slide, which shows today's speakers, Elana Chan, who's a PhD student at Stanford, and Katherine, who's a postdoc at South Nevada Water Authority. And then also just to alert you to the two exciting webinars that we have in January. We have Alessandro Zulli, who's a PhD student at Yale. And then we also have Janelle Ruth, who is from CDC, who's going to talk to us about wastewater and polio. So those two should be great. With that, I'm going to hand it off to Heseth, who's going to moderate the first speaker.
All right, thank you all for joining us. So I'm going to introduce Elana Chan, who's a PhD student at Stanford. If you want to go ahead and share your screen, and we'll get started.
All right. Good morning, everyone. My name is Elana Chan, and I'm a PhD student at Stanford University. And today I'm going to be talking about using wastewater-based epidemiology as a tool to monitor RSV. So the outline for my talk this morning is as follows. I'll begin with some background and motivation. So start off with just what RSV is and why we're interested in seeing if we can use wastewater-based epidemiology to monitor it. Then I will share the methods and results of a proof of concept study that was conducted to first just assess whether or not we can use wastewater-based epidemiology to monitor RSV. And then finally, I'll share how we're using wastewater-based epidemiology in real time to monitor the current RSV season. So beginning with some background, RSV stands for respiratory syncytial virus, and this virus is a single-stranded RNA enveloped virus that infects the respiratory tract of humans. And unlike COVID-19, which is a novel disease, RSV has been around for a while and typically follows a seasonal outbreak pattern. So cases generally peak in October and transmission is ongoing, generally throughout May. But in the past few years, RSV transmission has followed an irregular seasonal outbreak pattern. And common symptoms of RSV are very similar to other respiratory viruses. So this includes things like congestion, fever, and dry cough. And the reason why we care so much about RSV is that there are some populations who are at high risk for severe disease. So severe disease would include things like trouble breathing that might send someone to an emergency department. And these populations include infants, immunocompromised, and elderly individuals. So here are just two recent news headlines from this past RSV season that show why RSV is especially a concern right now. So experts are currently saying we're experiencing a tripledemic where we're seeing flu, RSV, and COVID-19 all circulating in our communities at the same time. And in addition, you may have also heard that a lot of children's hospitals across the US are seeing a large rise in RSV infections. So now moving on to the motivation for why we're interested in using wastewater-based epidemiology to monitor RSV. There are kind of two research questions that are kind of guiding this motivation. And the first is just whether or not we can even track RSV in the wastewater. So as we've all seen through the COVID-19 pandemic, there's been a lot of success with monitoring SARS-CoV-2 in wastewater. And this has been a really valuable tool for monitoring the COVID-19 pandemic. And so before this, there has been some research on RSV shedding in stool. However, these studies mostly just looked at presence and absence of RSV in stool. So there wasn't a whole lot of information out there in what quantities RSV is shed in stool. But it's also important to remember that anything that goes down the drain will make its way to the wastewater treatment plant. So this includes things like vomit, sputum, and saliva, which also may contain RSV, and these all go down the drain as well. So there's good reason to believe that this should work for RSV as well. And then the second motivating question is just how can we better understand RSV incidence? So there's a need in the US and around the world to better get data on RSV incidence. And the reason for this is that there's not a whole lot of data that's collected on infections. So as you can imagine, if you're a healthy individual, you're likely not going to get an RSV test, because getting an RSV test would require you probably to be highly symptomatic, probably go to like a hospital or see your primary care physician, and then the doctor would have to order you a test. So there's not a whole lot of data that's collected out there on RSV, and it's biased towards people who are displaying probably symptomatic infections and have healthcare. Another reason why there's a need for better RSV monitoring is that the symptoms of RSV are very similar to other respiratory viruses. So as I mentioned, the symptoms are very similar to things like COVID and influenza. So it can be hard to just determine which viruses are circulating just on symptoms alone. And then finally, there is that large public health burden associated with RSV, especially for infants, which can lead to morbidity and also economic burdens for the healthcare system. So the first step towards answering these questions was to conduct a proof of concept study to first just establish whether or not wastewater-based epidemiology will work for RSV monitoring. So the two main research goals of this study were first just to determine whether RSV can even be detected in the wastewater solids. And then secondly, if so, the next research goal was to assess whether the concentrations in the solids are going to be associated with traditional measures that are used for RSV surveillance. So the flow chart on the bottom here just shows the steps that were taken to conduct this study. So the first step was to develop an RSV assay that can be applied to wastewater samples. Then secondly, the next step was to apply this assay to wastewater solid samples. And this was all done in a retrospective manner because the study was part of a larger SARS-CoV-2 monitoring project. So samples that had been collected for that project were then analyzed for RSV using the assay that was developed. And then finally, the last step was to compare the RSV RNA concentrations in the wastewater solids with RSV positivity data obtained from the California Department of Public Health. So I'll go through each of these steps in more detail next. So beginning with the assay that was developed for this study, the type of assay that was specifically developed was a digital droplet RT-PCR assay, and it was developed using Primer 3+. And the target for this assay was the N gene, which is found on both RSV-A and RSV-B. And before using this assay on wastewater solid samples, it was first important to make sure it had good specificity and sensitivity. So specificity was first tested in silico using NCBI BLAST to make sure the target sequences did not overlap with any of the database. And then secondly, specificity was tested in vitro against the respiratory virus panel, as well as SARS-CoV-2 guide RNA, to make sure none of these other viruses were being detected as positive using the assay. And then on the flip side, it was also important to make sure the assay was both sensitive as well. So for a positive control, a mixture of both RSV-A and RSV-B was used to make sure that this sample was being detected as positive using the assay. And the assay was found to be both specific and sensitive, so then it could be applied to the wastewater solid samples. So the samples that were collected were obtained from 2 wastewater treatment plants across the Bay Area. So about 50 milliliters of settled solid samples were collected from these 2 sites. And the first site was the Silicon Valley Clean Water site shown in pink on the map. And this site serves about 220,000 people. And then the second site is much larger. It was the San Jose Santa Clara site, and it serves about 1.5 million people. And in total, 90 samples per site were analyzed for the 2021 RSV season. And like I mentioned, this study was conducted in a retrospective manner. So we could use this positivity data as shown in the red line here from the California Department of Public Health to guide the sampling frequency for samples that were analyzed. So for the first bit of the year where RSV positivity was essentially 0, only 1 sample every other week was analyzed for RSV. Then once the positivity rate began to increase a bit, 1 sample every week was analyzed for RSV. And then from the end of May onwards, 3 samples per week were analyzed for RSV. So once these samples were obtained, they were processed using the digital droplet RT-PCR assays. And so like I mentioned before, this was part of a larger SARS-CoV-2 monitoring project. So within 24 hours, these samples were analyzed for the SARS-CoV-2 N gene. They were also analyzed for pepper mild model virus, or PMMOV, which is a commonly used marker of fecal strength and can also be used as an internal recovery control. And then samples were also spiked with bovine coronavirus, which was used as an external recovery control. And then all the extracted RNA samples were stored at -80. And then after storage was when they were analyzed for RSV. So samples were stored anywhere between 400 to 300 days. And then afterwards were analyzed for the RSV N gene using the assay developed. And samples were also analyzed once again for the SARS-CoV-2 N gene to make sure that no significant RNA degradation was observed. And that was in fact the case, which affirms the validity of the results that I'll share in a moment. And then two other important details are that all the samples were processed in 10 replicate wells with all the appropriate controls, and that positive samples had to have at least 3 positive droplets across 10 merged wells. So the limit of detection was about 500 to 1,000 gene copies per gram. And before I move on to the results, I'll just share where the available data on RSV occurrence was obtained from. So like I mentioned, this all came from the California Department of Public Health, and they received this data from Sentinel laboratories across the state. So these laboratories report RSV positivity, so the fraction of their samples that are positive for RSV, to the State Department of Public Health. And so when I refer to positivity rate, that is the weekly fraction of clinical samples that are positive for RSV. So now moving on to the results, this is all for the 2021 RSV season. On the graph on the right, the top plot once again shows the RSV positivity rate across the entire state. And then the bottom two plots show the RSV concentration in gene copies per gram on a log scale. For the blue line for the San Jose Santa Clara site, which is the larger of the two, and on the bottom for the Silicon Valley Clean Water site. And so some key observations from these graphs are that at both of the treatment sites, samples were non-detect until about late June of 2021, which aligns nicely with the top graph that shows that statewide positivity was basically around 0 for that time of the year. And then from June onwards, we saw that concentrations began to increase at both of the sites, and this was similar at both of the sites as well. And this temporal trend in the increase in concentrations mirrored the temporal trend in the rise of RSV positivity across the state. And this trend was also similar when normalizing by PMMOB. And so this correlation was assessed using the appropriate statistical tests. So specifically a Kendall's tau correlation test was conducted. And as you can see with the tau values and the p-values, the correlation between the wastewater concentrations and the statewide positivity trends was both positive and significant. So in summary, the key findings from this study were first that RSV RNA could be detected in wastewater solids during a known increase in infections, and this was measured by the RSV positivity rate from the California Department of Public Health. And then secondly, the RSV RNA concentrations were strongly associated with the RSV positivity rates obtained from the Sentinel laboratories. So in summary, this study demonstrated that wastewater-based epidemiology could be effectively used as a nice tool to monitor RSV. And for more information on the methods and results, this study was published in ES&T Letters back in January, so you can scan the QR code here to obtain more information. So before I move on to how we're using this for the current RSV season, I'll share 2 follow-ups that were conducted to this retrospective analysis. So the first was sequencing of the RSV amplicon, and the second was differentiating RSV-A and RSV. So to just kind of check that we were actually amplifying our intended targets, Sanger sequencing of the amplicons generated by the primers was conducted. And so this figure here just shows 3 samples for RSV. So in well 5, you can see a sample that was non-detect for RSV, and well 4 is a sample that had low concentration, and in well 6 is a sample that had high concentration. So we could see that we were in fact amplifying the intended target, and this was further confirmed by making sure that the resultant sequences match those sequences in NCBI. And then secondly, 2 new assays were developed that were specific to RSV-A and RSV-B. So this graph here shows, again, the statewide positivity rate now in blue, and on the bottom, RSV-A in green and RSV-B in black. And so these assays were applied to solid samples from the San Jose site. And as you can see in this figure here, that this sewer shed specifically was most affected by RSV-B last season. And then once again, you can see that the decline in positivity rates was correlated with the decline in wastewater solids concentrations once again. So this work just kind of helped differentiate the 2 RSV types from each other. So now moving on to how wastewater-based epidemiology is being applied in a prospective manner for the current RSV season. I'll share kind of how the Sewer Coronavirus Alert Network, or the SCAM project. So this project is characterized by high-frequency sampling with quick turnaround time, and it has been ongoing since the start of the year. So there are 9 plants in this project across the Bay Area shown here in the map, and the population of these treatment plants ranges from about 10,000 people to 1.5 million people. And so each day a solid sample is collected from these sites and is sent to Verily, where it undergoes high throughput analysis with 10 replicates. And so the samples are then analyzed for SARS-CoV-2, SARS-CoV-2 variants, as well as respiratory viruses such as influenza, RSV, and human metapneumovirus. So today I'll just focus on the RSV results. So this data all is from 2022. So again, on the top, the red line shows the RSV positivity rate across the state from the California Department of Public Health. And the graph below shows the 7-day moving average of the normalized RSV concentration across the 9 scan sites. And so you can see once again that the increase in RSV positivity is correlated with increases in wastewater concentrations. And then I've inserted a dashed line where the statewide positivity data ends, just to emphasize why wastewater is especially useful for providing up-to-date information, because as you can see here, since samples have really quick turnaround time, we are able to have more up-to-date information from the wastewater compared to the statewide positivity data. So this just emphasizes one additional benefit of the wastewater, in addition to the fact that it's capturing everyone, not just those who are getting tested for RSV. And so all the data from the SCAN project is communicated publicly on wbe.stanford.edu. So you can visit this site to see all the sites as well as all the other targets. And the screenshot here is just an example from the San Jose site. So you can see that when I generated this morning, or took a screenshot, sorry, RSV concentrations are slightly less than where they were 15 days ago. And so this suggests that there hasn't been a huge change in RSV, but it may be starting to trend downwards a little bit. And so in conclusion, all of this work has demonstrated that wastewater-based epidemiology can be applied to RSV. And this is really useful because it can help support clinical RSV surveillance, because like I mentioned at the beginning, there's limited data collected on RSV infections. And then looking into the wastewater can help us identify RSV outbreaks. So as we saw with the most recent RSV seasons, especially in 2021 when RSV began to peak in June, or began to increase in June, looking into the wastewater can help us identify RSV outbreaks, especially during abnormal seasons. And since we saw that nice correlation between wastewater concentrations and the statewide positivity rate, this can help us infer RSV infection trends from just the wastewater. And ultimately, since this data is communicated publicly, it can help inform public health response. And then finally, since this has been successful for another respiratory virus, there is now interest, and there's also been work being done on expanding wastewater-based epidemiology now to other respiratory viruses, such as influenza. And so I just want to end with one example of how this is all being scaled up more widely. So this is an example of the wastewater SCAN project, which includes currently 84 sites across 20 states in the US. And this is possibly because of Verily, our commercial lab partner. And this graph here just shows RSV concentrations across all of these sites that are currently in the wastewater SCAN project. And you can see here that RSV concentrations are increasing across the US. And so to learn more or see the data, you can visit publichealth.verily.com. And so once again, my name is Elana. You can contact me here with any questions. And this QR code will take you to the wastewater SCAN program if you're interested in learning more and would like to obtain more information. And Ali Baim and Marlene Wolf are the scientific leads for this project, and their emails are listed below. And I just want to thank all the partners who are shown here on this slide for their help with all of this work. So thank you very much, and we can take some questions.
Thank you. So we have plenty of time for questions. As a reminder, you can put your questions in the Q&A box, and you can also upvote questions that you want to see answered. So I will kick us off here. Did you see any evidence that the wastewater data provided an early warning? I was actually curious about this as well, because it looked like the statewide data, it actually, when you showed the two plots, it looked like it kind of lagged a little bit, but maybe that's just where the statewide data is dominated from versus these sewer sheds. So did you see any evidence that it was an early warning in the sewer sheds you looked at?
Yeah, so the question was whether we saw an early warning from the wastewater data compared to the statewide positivity data. Haven't done like a whole lot of like in-depth analysis to see like, or just investigate like if there's like a lag time between the two. But I guess, like I mentioned kind of on this slide, that since the wastewater data does have that quicker turnaround time, it perhaps could provide some early warning signaling. It'll be interesting to see like when the next like report comes out from CDPH, like how this graph will look when I kind of update it with the latest data. So I hope that answers the question.
Yeah. Okay, the next question is, what do we know about asymptomatic RSV shedders?
Yeah, that's a great question. So do we know anything about whether asymptomatic individuals shed RSV. I do not know that the answer to that question, but I can look into that and follow up for sure.
Okay. And then Erin, sorry, in case, oh, okay, I'm missing, sorry. So CDC is emphasizing public health actionability. Are the public health agencies you're working with interested in using wastewater for surveillance of respiratory viruses? Why or why not, in your experience?
Yeah, so again, the question here was just whether public health agencies are interested in this data. And yeah, I mean, we communicate this all publicly and have received good appreciation for this data, and they find it valuable, the public health departments, in terms of how they actually are using this data. I think that's not really a question that I can exactly answer, but since these public health departments have been finding the data really valuable and useful, and we've received good feedback, I think it has been very beneficial for sure.
Here's another upvoted question that I guess I'm curious what your thoughts are. If you guys considered whether or not there are limitations caused by diaper use, if RSV typically impacts younger children and infants more, if it's not included in the wastewater as a result of that.
Yeah, that's definitely a great question. Something I thought about once, because since a lot of the populations that are at risk are those who may be using diapers. I think that's, yeah, a super interesting question. I'm honestly not sure how that might affect everything, but like I mentioned, anyone can get RSV. So like, for example, me in my 20s, I could get RSV and I would still probably shed it in the wastewater. So I guess that is one added benefit of this wastewater, is that everyone's being included, not just young children, because since those are the individuals oftentimes going to the emergency department, there is probably a good chance that a lot of the positivity data is includes a lot of young children. So I guess looking into the wastewater would still include everyone, and everyone still can get RSV. They just likely won't have a highly severe illness.
Yeah, okay. And then did you find any differences or challenges in monitoring RSV compared to SARS-CoV-2 in the methods or results?
Yeah, that's a great question. Looking into the methods of monitoring. Yeah, I'm not entirely sure. I guess obviously, like we all know, like a lot of us were getting tested for SARS-CoV-2. So maybe not so much now since there's a lot of the rapid tests, but at least earlier in the pandemic when a lot of us were taking the PCR test, there was probably a lot more data. So maybe I guess the positivity data may have been maybe a bit stronger or better for the SARS or COVID-19 compared to the RSV positivity, since not many people are actually getting tested for RSV. But in terms of the methods, I mean, we were able to detect RSV in high enough quantities to kind of like see the variability and the increase when RSV season began. So I think, yeah, it's been very successful, and we've seen it work for SARS-CoV-2, RSV, and influenza now. So I think there's this has all demonstrated that a lot of respiratory viruses are shed in the wastewater, and it's a really valuable tool to monitor it using wastewater-based epidemiology.
Okay, I have a question, which is, you know, you showed this cool thing that since you had the retrospective analysis, you could do these, change the sampling frequencies of how many samples per week you analyze. And then right now the wastewater scan is doing very, very frequent measurements. And even when there's, you know, not RSV happening or surging. I guess I'm wondering if you guys have thought for, you know, utilities or people or health departments that aren't able to analyze that frequency, how do you decide what the sampling frequency should be when you're in the middle of like a potential surging wave, right? Obviously, when you're in that point, more frequent is better, but before that, I guess, have you guys thought about that a little bit?
Yeah, definitely. So like I mentioned, this wastewater scan project, sampling is not done daily. Sampling is done 3 times a week. And so like you mentioned, obviously more samples is definitely better. But other work that's have kind of looked at like trends and everything has found that, yeah, usually like at least like 3 days a week, maybe 4 is definitely sufficient. Obviously, yeah, like I said, more is better, but when you are experiencing or seeing a rise in infections, if you're able to do so, I think increasing frequency would be beneficial. So say like you're generally only sampling 2 or 3 times a week, but you're seeing rises, then maybe if you have the capacity to do so, bumping up sampling to like 4 or 5 times a week could be beneficial. So kind of maybe adopting like an adaptive approach could be really beneficial, so that you're not sampling on like a daily basis when you're really not seeing any Rs. Could be a more practical approach to this.
Yeah. So do you know if the California Department of Public Health have the RSV data disaggregated by age?
Yeah, so the question was about whether it's disaggregated the positivity data. And when I download the Excel file, there is no like disaggregation. It's just like a percentage each week, but that could be definitely very interesting to look at for sure.
Yeah, especially for like that diaper question, I guess, to see how biased it is for young folks or children and infants. Okay. Is it more challenging to, this isn't wastewater related, this is on the clinical side, if you have any knowledge of this, if it's more challenging to develop a rapid test for RSV, or is it just that it's lower priority than COVID was as far as like the antigen testing?
Yeah, I'm not sure I can answer that in terms of like how easy it is to develop a rapid test, and that's not my area of expertise. But I mean, I can imagine like obviously there was huge demand to get a rapid test for SARS-CoV-2 since that was causing a global pandemic back at the start of the year.
I guess it's also maybe we're all more comfortable now, like, or we would all be interested in maybe testing ourselves for different things now.
Yeah, for sure.
How we were pre-pandemic. Okay, I think this might be the last question. I don't recall this, but was there, the clean water showed high concentration of RSV? Have you ever checked the tap water concentration?
So is the question if we've checked the tap water for
Yeah.
RSV? Not to my knowledge. Yeah.
Okay. But I guess you guys have controls. I guess I wasn't sure what the clean water was. So maybe Petra, if that wasn't a satisfying answer, maybe you can follow up directly with Elana.
Yeah, for sure.
But thank you so much for your wonderful presentation. And I am happy to hand it off now to Katherine, who is a postdoc at Southern Nevada Water Authority. And Lauren Stadler will be guest moderating her talk. So thank you so much.
Hello, everyone. Today, I'm excited to talk about a project that we have been working on here in Southern Nevada, and we just recently wrapped it up and submitted it. And this project highlights a case study of how ongoing SARS-CoV-2 wastewater monitoring efforts can be adapted towards emerging or re-emerging pathogens of interest. First, I want to start out by acknowledging the people behind this effort here at the Southern Nevada Water Authority, specifically Casey Barber, who has been instrumental in this project. She's from the School of Public Health at the University of Nevada, Las Vegas, as well as Katerina Papp and Dan Garrity here at SNWA. First, a little background on Candida auris. Candida auris is an emerging multi-drug resistant yeast. It can cause severe infections, and it spreads easily between hospitalized patients and nursing home residents. It was first identified in 2009 in Asia and has quickly become a cause of severe infections around the world. C. auris is particularly deadly for immunocompromised individuals, with more than 1 in 3 patients who experience invasive infections resulting in death, as a very high case fatality rate. C. auris is a fairly large, hardy fungal pathogen with a DNA genome approximately 12 megabase pairs in size. There are 5 geographically distributed and genetically divergent clades, with low genetic diversity between these clades. Since it has only emerged relatively recently, some hypothesized reasons for emergence include climate change creating more desirable environmental conditions for reemergence or emergence, as well as the increased use of antifungals and fungicides. One aspect of C. auris that sets it apart from other common Candida fungal pathogens is its multi-drug resistance. Some strains are resistant to all available classes of antifungals, and 90% of clinical isolates tested in one study showed resistance to at least one antifungal and 30% resistant to at least 2 antifungals. They also have some protection against typical healthcare cleaning supplies and has been shown to form biofilms in urinary catheters, central venous catheters, and other medical devices, which makes it quite tricky to treat. It can survive for up to 2 weeks on surfaces. It can be carried on the skin without causing an infection, which I'm going to be referring to as colonization, which allows it to spread to others. Transmission is common in a hospital setting through surfaces, including bedding, equipment, floors, sinks, handles, you name it, it probably can transmit Candida auris. Here in Southern Nevada, we are experiencing a major severe outbreak of C. auris infections in healthcare facilities and long-term care facilities throughout the valley. The first clinical case in Southern Nevada was found retroactively in a sample collected in August 2021. And in May 2022, the health department requested CDC EpiAid. As of October 24th, there have been a total of 600 cases, and half of all Candida auris pediatric cases in the United States have occurred here in Nevada. There have been 63 deaths so far, with caveats being that it's unclear whether or not those deaths have occurred with C. auris or from C. auris. This outbreak has impacted 22 facilities, 10 acute care hospitals, 8 skilled nursing facilities, 4 long-term acute care facilities. So this is a very important public health problem facing us here in Southern Nevada, and it's only growing in other places across the United States as well. Candida auris is a good candidate for the application of wastewater-based epidemiology. It has been shown to colonize the rectum and urinary tract, and a mouse model has shown that viable C. auris can be shed in urine and feces. It's also possible that it is shed in sputum, and it has been detected before in hospital sinks, drains, as well as in a couple of environmental samples from India. At the beginning of the summer, we sent a sample of our Clark County wastewater to the Utah Department of Health, where they successfully cultured Candida auris out of a sample, and subsequent sequencing linked that isolate to cases in healthcare facilities here. So our question, can Candida auris be detected in wastewater during an ongoing outbreak, was yes, it was successfully cultured. The Southern Nevada Water Authority SARS-CoV-2 monitoring effort has been ongoing since early 2020 and involves weekly sampling from 8 wastewater treatment plants across the valley. The existing infrastructure and protocols make the SNWA an ideal place to expand WBE efforts towards other targets. And knowing that our Utah public health collaborators successfully cultured C. auris, we decided to adapt the CDC's diagnostic qPCR assay to our wastewater samples collected on a weekly basis. Here's a little background on the Southern Nevada sewer sheds and our wastewater sampling program that's ongoing. We have a total of 6 sewer sheds served by a total of 6 facilities, and it has different divisions based on the source and type of wastewater that comes in. The main difference between our SARS-CoV-2 detection method and our method for detecting C. auris centers around what part of the wastewater we are concentrating and extracting the DNA from. With SARS-CoV-2 concentration and extraction, we focused on the liquid wastewater, in other words, the supernatant after the centrifugation step. With C. auris, we suspected that we would have better luck extracting from the suspended solids, so we focused on the pellet formed after a centrifugation step. So I'm going to walk you through our methodology for detection of C. auris. First, we took a total of 9 weekly samples from 6 treatment plants, which represent a total of 7 different sewer sheds. 2 samples were 10-liter samples, and the rest were 150 milliliter samples, which is consistent with our ongoing monitoring campaign. The samples varied in type and source and include grab or composite samples of raw effluent or effluent that has undergone a settling step or primary effluent. For the 10-liter samples, we concentrated the sample down to approximately 100 milliliters using hollow fiber ultrafiltration. We then centrifuged both the raw 150 milliliter samples and the HFUF concentrate samples and poured off the supernatant to separate out the suspended solids. We then transferred a small amount of the pelleted solids to our extraction kit, the Power Soil Extraction Kit, and extracted the DNA from the pellets. In order to quantify C. auris in our samples, we used the CDC designed and validated assay for clinical diagnosis of C. auris infections. We adapted it to our qPCR instrument and our reaction volumes, but we used the same primer and probe sequences and cycling conditions. Now I'm going to walk you through our findings by sewer shed, starting with Facility 1. Facility 1 serves the largest population and geographic area, and we collected 2 samples from Facility 1, one from the raw effluent and one from primary effluent, which is raw effluent that has undergone a solid settling step. A solid point represents a detect. A hollow point represents a detect with only one replicate being quantifiable. A star represents concentrations that are below the limit of quantification, and if you see a red X, that will be a non-detect. The concentrations range between approximately 3 and 5 log-10 genome copies per liter, and these are uncorrected for recovery and unnormalized concentrations. This area includes 6 healthcare facilities that have experienced C. auris outbreaks during our sampling timeframe, which was July 5th to September 6th of this year. Facility 4, which is not shown on the map, is a composite of facilities 4A and 4B. 4A receives solids and overflow bypass from Facility 2, so all 3 of these facilities are closely linked. We see very high consistent concentrations from Facility 4 and 4A with more intermittent and variable signal from Facility 2. This area served by Facility 2 and 4A contain 4 healthcare facilities that have experienced Candida auris outbreaks during our study period. Facility 3 has our second largest service area and population and our largest number of healthcare facilities experiencing outbreaks, with high consistent concentrations ranging between approximately 4 and 5 log-10 genome copies per liter. This facility, Wastewater, has our highest C. auris concentrations and a 100% detection rate. Finally, facilities 4B, 5, and 6 have our lowest concentrations with the most intermittent and variable signal. Facility 4B and Facility 6 sewer sheds, as of September 6th of this year, do not serve any healthcare facilities experiencing outbreaks of Candida auris. Facility 5 does serve one outbreak facility, and we do see an intermittent detection there. Overall, throughout this sampling campaign, Candida auris was detected in 72 of the 91 wastewater samples analyzed, with a 79% detection rate. So far, the work we've done is fairly descriptive in nature and fills the surveillance role within wastewater-based epidemiology, but we would like to be able to link it to the outbreaks we are seeing in these healthcare facilities. So far, we have been working with our community partners, and when we saw an uptick in concentrations at our Facility 2, we reached out about potential increases in cases in healthcare facilities served by that sewer shed, which they did confirm was happening. But in order to quantitatively link the two, we need specific case data that is, it's more sensitive, especially with the small number of infections relatively compared to other pathogens like RSV or SARS-CoV-2. And also we need to be able to verify these results with building level wastewater monitoring. Building level wastewater monitoring is in the works with some of our public health partners in hopes that we can create relationships with hospitals in the area and potentially install some auto samplers, which could help give us more fine resolution results. We also have quite a few unknowns still to parse out. For instance, we know that C. auris lives and grows in biofilms. And so we don't know if it is growing and reproducing in sewer biofilms, or if it would constitute a confounding factor after initial introduction of C. auris. We ultimately piloted the development of methods for monitoring C. auris in wastewater and showed that our methods displayed high sensitivity and reproducibility. We tested environmental controls, including those from the Las Vegas wash, which receives the outflow from all of the wastewater treatment plants, as well as stormwater and urban runoff. We also tested an environmental control from Lake Mead, and all of our environmental samples tested negative. We were also able to validate our qPCR method using spiked samples provided by our partners at the Utah Public Health Laboratory. And we showed that our qPCR method is specific to Candida auris. Ultimately, a goal with this project and a milestone, hopefully on the path forward for wastewater-based epidemiology, would be to be able to provide a community-level warning signal that can trigger hospital-level screenings that can ultimately help prevent the spread of this infection. Some critical needs on the path forward for wastewater surveillance of C. auris, as well as any additional pathogens we add to our wastewater surveillance portfolios, is pathogen shedding rates. This is a well-worn point in WBE, but to be able to quantitatively link concentrations of pathogens in wastewater to case counts, it really is important to have well-described and characterized shedding rates. We also could use more information on the fate of pathogens throughout the sewer system so we can better inform the way we interpret this data for public health actionability. On that note about data interpretation, we need to really value and nurture our relationships with our community health partners and public health decision makers. If the ultimate goal with WBE is to provide actionable data, we need to be able to help our partners make informed decisions by brainstorming and working on ways of communicating our data and the usefulness of our data simply and effectively. And I kind of buzzed through that talk fairly quickly, but I would like to give a big shout out to our collaborators, specifically at the University of Arizona, Dr. Inez and Dr. Schmitz, as well as Dr. O at the UNLV. And a huge thanks to our public health partners at the Southern Nevada Health District, as well as the Nevada State Public Health Laboratory, the Nevada Department of Health and Human Services, and the Utah Public Health Lab for instigating this study and also providing us with spiked samples. And finally, a big thanks to our wastewater facility partners who have been with us since early 2020 and have always been extremely helpful and willing to collaborate with us on all of our different projects. And with that, I think there's plenty of time for questions.
Thank you, Katherine, for that excellent presentation. Just a reminder to drop some questions in the Q&A and you can upvote them there. We will start with the first question, which is on, it appears that your highest detection was in facility 3. Can you remind us what the sewer shed population was for that? And did you see any relationship between sewer shed size and detection?
I could actually run back to that slide on the population, but I also have a note here. Facility 3 population was around 255,000 individuals. That is our third largest facility that we sample from. And the question, did we see a relationship between, was was the question, do we see a relationship between facility size and Candida auris detection?
Yeah, between sewer shed size and detections.
That's a great question. It's a bit difficult to parse out because sewer shed size also correlates to how many healthcare facilities are in that sewer shed. So we did see more Candida auris in our larger sewer sheds, but that also could be because we have more healthcare facilities in those sewer sheds as well. So that relationship between population and Candida auris detection is a little bit difficult to see what's causing that. Is it because there are more people, or is it because there are more healthcare facilities? But yes, ultimately we did see more Candida auris in the larger sewer sheds. Great.
Next question is, do you know if Candida auris signal is reasonably robust to disinfectants? There's a comment about how many groups have struggled to detect SARS-CoV-2 from hospital water, presumably due to disinfectants degrading the signal. Is that not as big of an issue for this pathogen?
That's a great question. We are assuming that our detection of Candida auris in wastewater is from hospital wastewater. And that is a major assumption that we would definitely need to check. If that's true, if the major source of signal is hospital wastewater, then we would, I think it would show that disinfectant addition to wastewater isn't impacting the signal. However, we haven't shown that. I think that would require facility level sampling, which hopefully we'll be able to do in the future. But currently, based on our assumptions of the source of the C. auris signal, we could potentially say it isn't having a major impact on Candida auris concentrations. But that is a major assumption that our signal is from the wastewater or the healthcare facilities, which we haven't been able to definitively show yet.
So this is kind of a, I would say, follow-up and related. Have you ever looked for it in the effluent of the wastewater treatment plant? And this might tell you something about how effective wastewater treatment plants are at removing it that also have disinfection.
That's a great question. One of our environmental controls is from the Las Vegas wash, which basically is where all of the wastewater effluent gets discharged. And we did not detect it in the Las Vegas wash sample. There is potential for degradation between the point of discharge and the sampling point for the Las Vegas wash sample. So to have more specificity, I suppose we should test at the wastewater treatment plant effluent directly. But based on what we saw in the Las Vegas wash, it is being removed through conventional wastewater treatment.
Are all of the infections in this area from clade 1?
That is a great question as well. And I do have that data. I believe I will have to reach out to you with that answer. I do have that data, but I don't have it close at hand.
Okay, Katie Scott asked that one, so maybe she can follow
I'll make a note. Yeah,
directly with after the talk. Okay, next question is, you mentioned that you're able to culture Candida auris out of one of your wastewater samples. Have you done that again after that first culture? Have you been able to do that repeated times?
Great question. I just want to clarify that our collaborators at the Utah Public Health Laboratory are the ones who are working on the culture method. And they actually just got a paper accepted for publication on their culturing process with C. auris. They've had a bit of difficulty culturing Candida auris. There are a lot of related yeasts that grow very similarly. And I know that they've been overcoming many hurdles with that culture method, but there is a recently released or accepted paper that goes into more detail on their culture method. And I can link that to you as well.
Wonderful. I think a lot of people would be interested in seeing that paper. Let's see. Next question was, is it possible that some of the Candida auris signals coming from individuals that are not in hospitals? Can you kind of comment on that? And your insights on what you think the proportion are of carriers of Candida auris in the population, or infections that are not in hospitals or skilled nursing home facilities?
That's a great question. And that's been one that we talk about a lot. Basically, are asymptomatic individuals, healthy individuals carrying Candida auris on their skin and shedding that into the sewer as well? And that is a big unknown. Our collaborators at the University of Arizona, Dr. Inez, believes, based on his work with Candida auris, that if you are a healthy individual and you have a C. auris colonization, you clear it very quickly. So if you are colonized with C. auris as a healthy individual and do not display symptoms, you're clearing that infection very quickly within a very short amount of time. Healthy people bring it into healthcare facilities, and that infects people who are sick in these healthcare facilities as well. So there is for sure colonization on healthy individuals. The impact of that on shedding is unknown, and a little bit more clarity, I think, can come from site-specific monitoring. So installing those autosamplers at hospitals could maybe give us a better idea. If we compare the community rate to a building level rate, maybe we can get a better idea of what's circulating in the community. But another clue that I think is, it's an important clue in our trying to figure out what's going on with C. auris, is that our Utah collaborators looked in their wastewater using our method for Candida auris, and there was no Candida auris circulating in their sewer sheds. So it is specific here in Nevada compared to our collaborators in Arizona as well. Arizona and Utah both have looked for Candida auris in their wastewater and have not seen anything. So that's an important clue that maybe it is directly related to this outbreak, and it's not just circulating in the community asymptomatically. But ultimately, these are all big questions that we would really want more clarification on.
So maybe another question about potential future research areas and potential like confounding variables. Do you have any plans to determine whether there's growth occurring in the sewer pipes, and whether, you know, biofilm formation is potentially, you know, impacting your signal?
No plans as of yet, although I think that would be really interesting to start looking at biofilm formation and the biofilms that are already existing in these sewer lines, but we don't have any plans as of yet to do that.
Right. There's another question / comment that's saying that if it can indeed colonize and grow in the sewer network, then perhaps that would actually prioritize monitoring Candida auris above just viral tracing to ensure that we can manage the pipeline to ensure it doesn't become a source. Yeah, do you have any thoughts on that? And do you see this organism as a potential transition point away from human health to infrastructure health monitoring?
That's fascinating. That's a very interesting point. That's a very great point. I think that would definitely highlight the need to start looking at these biofilms in the sewer shed to see how, looking at infrastructure infection almost more than public health infection. Like, are we having a colonization of our sewer shed by Candida auris, and could that potentially transmit into the population? That's a fascinating question. And I think that definitely would highlight the need for continued testing, maybe more point source testing throughout the sewer shed, as well as building level surveillance. That's a good point. Thank you.
Yeah, that's a interesting question when you think about all the different pathogens that we might want to start monitoring for. Okay, here's another question. I think it's somewhat related to the previous one that's about sewer shed size. But if a wastewater treatment plant serves more facilities, have you noticed there's a more diluted effect in the increase in C. auris detection in that sewer shed when there's an outbreak in one of those facilities? And how does this impact your ability to compare across different wastewater treatment plants?
That's a great question. We see higher concentrations of Candida auris in sewer sheds that serve higher amounts of healthcare facilities. But since this was only a 9-week long sampling campaign, Unfortunately, parsing out those direct comparisons between case counts and sewer shed, it's a little bit more tricky. So we haven't looked too specifically at those factors yet.
Okay, here's another question. Since suspended solids were chosen for analysis, would using influent that has already gone through settling reduce your sensitivity?
So we did see a significant decrease in Candida auris concentrations in our primary effluent compared to the influent for that wastewater treatment plant. That was facility 1. However, we did detect it still. So we did successfully detect it. But if you are considering implementing this assay in your wastewater solids, I would say you would probably have better luck looking at influent solids rather than influent that has already undergone a settling step, because we did see a significant decrease in concentration. And so if you're looking to increase the chances of detecting Candida auris, I would recommend looking at influent solids.
That's helpful. That's really helpful. Okay, next question is, what do you think the likelihood is that wastewater could identify Candida auris before identification of cases in hospitals? And if this was regularly implemented, would it need to be done for a specific facility in perpetuity to provide that rapid info?
That's a great question. And we've been trying to understand through our public health partners a little bit more about how hospitals are like surveilling for Candida auris, what their already existing infrastructure for surveillance is. And it would depend on, it would be on a hospital by hospital basis on what their already in place protocols are. If they require, I know some hospitals require all, specifically long-term care facilities require all new people who are moving in to be tested for Candida auris colonization before they can move in. So that's one surveillance method that obviously wastewater surveillance cannot proactively test individuals who haven't yet even moved into a facility for Candida auris. But I know some hospitals also only surveil their patients after there has been a case. So if there's not an ongoing surveillance program, a wastewater surveillance program could potentially trigger a hospital-wide clinical surveillance. So it does depend on the program that's already in place at these different healthcare facilities, whether or not having site-specific wastewater monitoring would be useful. And that kind of highlights how important it is that we have good relationships with our public health partners in the community, especially hospitals, because if we were to install an auto sampler at a hospital that's already doing regular Candida auris surveillance clinical testing, it may not be useful at all. Whereas for maybe a big hospital that only does reactive testing, it might be useful to trigger some of these surveillance testing. So that's a very good point. And there's a lot of nuance there that's different from site to site.
Great answer. We only have about 1 minute left. I'm just going to echo some of the comments here that are saying beautiful talk and Q&A. Really exciting work that you're doing. Everyone's excited to see these publications and the future work coming out of your group. Is there somewhere we can look to find a central location to find recent updates being posted that you would recommend?
That's a great question. We do not have a certain, like, we don't have a space that we're updating regularly with updates right now, but that's inspirational. Maybe we will create something like that to keep people updated. But right now, if you want to follow me on Twitter, I'll tweet out when how our papers are coming along and different updates with methodologies, if that's useful to people, or you can reach out to me via email, and I'm always happy to respond to questions that way as well.
Amazing. Everybody follow at Cat Crank. Thank you so much. We're at the top of the hour, and see you next time.
Thank you all.